everybody, and welcome to the KickStart series. I am Dr. Meenakshi, one of the mentors at StudyMRCOG. Not just watching video, please do like and also subscribe to the channel so that you will be getting more and more updates, and it's definitely going to be beneficial to you. So since we always start with a quote, never stop trying and never stop believing, and never give up. So the topic for today is going to be HIV in pregnancy. This is one of the hotspots for MRCOG Part 2, especially very, very important area where a lot of questions can be expected. So what all you need to learn in this topic is the drugs which are used and their category, not necessarily the regimen, whether they use 3 drugs or 4 drugs, what are the drugs they use. You need not memorize all that, but at least like which drug falls under like NRTI, or which drug falls under NNRTI or protease inhibitors. I think that basic outline we all need to be aware of. And then the CD4 count and viral load. Like for what CD4 count or for what viral load do we take the decision for cesarean section, or when do we opt for vaginal delivery? When is the load, at what load the vertical transmission would be high? These need to be learned. And when do you want to start the antiretroviral therapy? Like in which trimester you start, at what viral load do we start? This we'll be covering it in this class. So that is also one of the important points which we need to learn. And what are the indications for cesarean section in a HIV pregnant woman? Like apart from obstetric indications, what are the indications per se in related to HIV wherein we go for cesarean section is also important. And how do we parameter, like how do we gauge the infection, like how high is it, how severe is it? It's based on the viral load and CD4 count. So that is also like how frequently we need to do the blood tests, etc. That needs to be learned. So there is a study which states that the prevalence of depressive symptoms among women who live with HIV is nearly 30%. And the prevalence of postnatal depression is about 30 to 53%. All these numericals are very, very important and can be expected as questions. So what are the some of the factors which could contribute to postnatal depression is, supposingly the woman has already had any kind of mental health issues, or if there is any kind of financial issues or any housing concerns, any immigration problem, like if she's a migrant, or lack of social support, if there is any HIV related stigma or intimate partner violence, the prevalence is found to be around 14%. Or in case of any substance misuse or a lack of support from a partner, these are some of the risk factors for the woman to develop postnatal depression. So whenever a woman has been turned out to be HIV positive, it is important that we assure her the confidentiality, especially with some family members and with friends. And we tell them that as healthcare providers, we need to be aware about her HIV status, and also the person who is intimately involved with the pregnancy, we need to disclose it. For couples where a male partner is HIV negative, advice should be given regarding condom use and also post-exposure prophylaxis following sexual exposure if a woman does not have an undetectable viral load. Whatever it is, post-exposure prophylaxis is also very important. Plus, safe sex practices like usage of barrier methods and all also needs to be counseled. So whenever there is a HIV positive woman, either she's been detected during pregnancy or she's already a HIV positive and she has become pregnant, we have to give her care under a multidisciplinary team that would be involving a HIV specialist, an obstetrician, a pediatrician, specialist midwife, and also it's important that we involve the woman's GP and health visitor after you take the consent from her. These are the important people who you involve. Apart from that, based on the situation, you could also involve patient advocates or legal advocates, some social workers, clinical psychologists, psychiatrists, counselors, health advisors, citizen advice bureau workers, interpreters in case if it is necessary, community midwives and pharmacists, adult and pediatric clinical nurse specialist and health visitor. So based on the situation, primarily you are going to involve an obstetrician, a HIV specialist, and a pediatrician. Plus, additionally, these people would be involved as and when the need arises. So since we've already seen that there is an incidence of having depression in HIV positive women, which could go even as high as up to 50%. Therefore, the NICE guideline recommends that we need to assess for depression at the time of booking, at 4 to 6 weeks postpartum, and also at 3 to 4 months postpartum. You put her questions like, has she been feeling low during the last 1 month, or if she's not interested in doing things that she was interested before, and is she feeling low? Or these questions you can ask and you can assess the depression, which needs to be done according to these times. So this is very, very important. And then you will be screening her for the sexually shared infections as well. So we see that the incidence of having the genital infections, the sexual infections or bacterial vaginosis, it could be between 1 to 4%. So we have to screen them for those infections as well, because it is known that the risk of having a preterm birth would be doubled up in case there is associated sexually shared infection. So it is important that we screen so that the after effects could be reduced. So whenever you screen for the infection, it should be done at the time of booking, and you can repeat it at around 28 weeks. Whenever earliest possible time, we have to get the screening done. And if at all she turns positive for any of the infections, it is important that we treat them according to the BASH guidelines. Suppose a woman is a HIV positive and she's got a history of herpes, that is genital herpes. Whenever she's got this associated infection, even when there is a history of that, it is important that we give suppressive acyclovir 400 milligrams 3 times a day from 32 weeks. This is an extremely, extremely important point. And we give the suppressive dose so that we can reduce the HSV transmission and shedding at the time of delivery. Especially when you're planning for a vaginal delivery, this need not be skipped. This is very, very important. This should not be skipped. And we've seen that with HIV, whenever there is a transmission, there is an increased risk of having chorioamnionitis or prolonged membrane rupture or even premature birth. So whenever there is any associated infection, it is important that we treat it as well. So if she's got a history of genital herpes, please do consider giving suppressive acyclovir from 32 weeks of gestation. And this is one important point. How do you investigate a HIV positive woman? Suppose she is now, at the time of booking, you're doing some routine tests and you find out that she is HIV positive. You need not do any kind of additional baseline investigations. Just like a routine, however you do for a routine pregnant woman, we follow the same investigations for her as well. But we do another thing which is called as HIV resistance testing. That is like to which drugs that she is being resistant to, that needs to be tested. And whenever you see, firstly, you have to, if she's coming to you at a late time, suppose she's presenting to you at 3rd trimester, it's important that you put her on ART. The regimen should be started and then you send for resistance testing. In case she's found to be resistant to any of these, you can change the drug accordingly. You need not wait for the resistant results, provided she's presenting to it late when she's coming to you in the 3rd trimester. Now, how do you investigate? Just as I've discussed in the first slide itself, like how frequent do you do investigations and how do you, what are the parameters on which you gauge? This is very important from now on. Please follow the flow charts. So whenever she is already HIV positive and she is already taking a retroviral therapy, antiretroviral therapy, now she becomes pregnant. So what do you do is, in order to test the severity of infection, we do a CD4 count once a baseline level should be done. Plus, we also do it at the time of delivery. So whenever you're testing, you already know that she is HIV positive. The only thing that you need to know is how severe the infection is. So do a CD4 count at the baseline as well as at delivery. And the next one is, suppose she's a normal pregnant woman who's got HIV during pregnancy. Now you have started on antiretrovirals during the pregnancy. So when do you do the CD4 count? We do it whenever you're initiating your antiretroviral therapy. Just as we discussed, we do the resistance testing. So similarly, before starting this, it is important that you take up the CD4 count as well. And then you do it at the time of delivery. So EMQs can be asked in this area. Like, for example, you would be given the set of options and that you will do it at booking at 14 weeks, 18 weeks, 20 weeks, 24 weeks. And you can be asked like options like that. Just remember that you have to do one baseline level and then at delivery. That's it. And supposingly, you have already started the woman on CRT in pregnancy. How frequent do you monitor her LFTs? Because these drugs would be metabolized by liver. So testing for liver function is extremely important. So once you're doing the CART when you're starting it, along with your CD4 count, do one LFT as well. And then whenever you do the routine blood test, so based on the patient's condition, we keep doing the CBP, the basic blood count. So at that point, it is also important that you do the LFTs as well. So because you're starting it for the first time, you have to see how it is having an impact on the patient. So that is the reason we have to do the LFTs at the time of initiation and with every blood test. Supposingly a woman is already on CART and she's become pregnant, it means that she's already on such treatment. So therefore, liver monitoring might not be required very frequently. Now, how frequent do you have to test for your viral load? So it is important that we test it about, firstly, you're putting her on an antiretroviral therapy. So we have to take up the viral load about 2 to 4 weeks after you start the treatment to see whether she is responding or not. And then once in every trimester, it has to be done. And then once you do it 36 weeks, and then you do it delivery. When you do it 36 weeks, you decide the mode of delivery then and there based on the number of viral copies. We will be discussing that in upcoming slides. I just want to tell you that once you start the antiretrovirals, do a count about 2 to 4 weeks after the delivery so that we get an idea whether she is responding or not. And then you do one level each in one trimester each, and then at 36 weeks, and then at the time of delivery. So these are the group of drugs, like which drug will fall under category, that is important. Knowing each and every regimen is definitely not required. So NRTIs, we've got stavudin, lamivudin, zidovudin, tenofovir, and abacavir. And NNRTI, efavirenz, nevirapine, and rilpivirine. Integrase inhibitors, all the grace, so gray will come there, like raltegravir, dolutegravir, darunavir, and atazanavir. All the navirs or virs, they will be coming under integrase inhibitors. So normally if the woman is not on any kind of CART, she's not on antiretrovirals, and for the first time you see that she's HIV positive, and you see that the viral load is less than 1 lakh copies. So the regimen that you prefer is tenofovir, double dose with emtricitabine with rilpivirine. So once you start the CART, it is essential that she has to take it for lifelong. It's not that it is come in pregnancy and after delivery she has to stop. No, since it's a chronic disease, we have to continue it for lifelong. Suppose she is already taking dolutegravir and she has become pregnant. So we have to tell her that there is a minimal risk of having neural tube defect. So 5 milligrams of folic acid is recommended. Apart from dolutegravir, on any other ART drugs she's on, she can just take the regular 400 microgram dose, and higher doses definitely not required unless she does not have any other risk factors like sickle cell or obesity or any other condition where we give 5 milligram. Excluding those, if she's just taking other drugs apart from dolutegravir, you put her on 400 micrograms. And then we have to take it until 12 weeks of gestation, until the end of first trimester. So we have a category which is called as elite controllers, which means that the viral load in the blood is very much undetectable. So even in such conditions, the BIVA guideline recommends that you have to start on antiretroviral. Whatever her CD4 count is, whether she's symptomatic, not symptomatic, whether she's detected for the first time, or whatever it is, even if she's an elite controller, you have to put her on the antiretroviral therapy. So supposingly now you have seen that for the first time that she's HIV positive, or you're seeing that she's not taking any kind of treatment. What would you do? So this mainly depends on the viral load, as we have discussed. Suppose her viral load is less than 30,000 RNA copies per ml. That means that the load is less than 30,000, means it is not very severe. So what we do is we have to start the drugs in the second trimester. Why we do that is because the viral load is less. What we do is we try to avoid the antiretrovirals during the first trimester so that whatever minimal risk of neural tube defects or whatever minimal teratogenic risk is there, that would be eliminated. So if she is less than 30,000, it is okay. We can start it in the second trimester. Suppose she is having between 30,000 to 1 lakh. Then what we do is immediately once the second trimester begins, that is immediately after she's at 12 weeks, we have to start her on antiretrovirals. Suppose if the viral load is more than 1 lakh, that means that it is a very severe case. That means the viral load is very, very high. And if the CD4 count is less than 200, which means that the immunity is also less. In such cases, we have to start it in the first trimester itself. Whatever the condition is, make sure that you start it by 24 weeks of gestation. So this is also an extremely important slide. Questions can be asked from this as well. EMQs can also be expected from this. Less than 30,000, wait until second trimester. 30,000 to 1 lakh, you start it immediately once the second trimester begins. And if it is more than 1 lakh or the CD4 count is less than 200, you have to start it within the first trimester itself. And here, whatever it is, make sure that you have to start the CART by 24 weeks of gestation. And now, what we do is the integrase inhibitors can be included in the CART whenever the basal load is more than 1 lakh. That means that the virus is replicating like very much. It's very high if it's more than 1 lakh. So what happens is in such case, or whenever you have put her already on an antiretroviral treatment and after 2 to 4 weeks, you see that the viral load is not declining as you expected. In such cases, you can include integrase inhibitors as the third agent because integrase inhibitors, they are known to reduce the viral load very rapidly as compared to other drugs. Otherwise, in that conditions, there are these two indications where you consider the integrase inhibitors as the third line of drug. Supposingly the woman is presenting to you in the third trimester. So that is after 28 weeks. That is almost like she is 12 weeks close to the delivery. So you don't wait for the resistance testing. You immediately start her on CART. And you wait for the results, and based on that, you can change the drug accordingly. Supposingly, you see that the viral load you have taken and you're not really sure of what the viral load is or if it is more than 1 lakh. Then you have to go for a 3-drug regimen or a 4-drug regimen, which has raltegravir, 400 milligram BD, or dolutegravir, which is 50 milligram OD. Now, dolutegravir is known to cause neural tube defect, but now she is in third trimester. So there will be no risk at all because the neural pore is already closed. So therefore, it can be given in the third trimester. As we've just discussed that protease inhibitors can be included whenever you want to have a rapid decline in the viral load, is it not? Now she is more than 1 lakh, now she is in third trimester, so include the protease inhibitor. It is known that they reduce it to less than 50 copies per ml by 36 weeks of gestation when you compare it with the other group of drugs like NRTIs and NRTIs as compared to other drugs. Prefer this protease inhibitors because they are known to reduce the viral load. So NRTI, everything would be used as the backbone. They are anyways the part of the skeleton of the CART. But in the third line of drug, it is better that you choose the protease inhibitor. Suppose you've got an untreated woman who's presenting in labor. Now you are in the labor ward and suddenly a woman walks in and she's in labor and you see that she is HIV positive. When you do the spot test, you see that she is HIV positive. Then what would you do? You have to go for nevirapine 200 milligram start dose plus zidovudin 300 milligram BD, lamivudin 150 milligram BD, and raltegravir 400 milligram BD. Plus, IV zidovudin needs to be given for 2 milligram per kg for 1 hour, followed by the maintenance dose of 1 milligram per kg per hour until the cord clamp is done. This is mainly used to reduce the viral transfer across the placenta so that the viral load could be reduced to the baby, the transfer. So that's the reason whenever she's presenting you in labor, we are not sure since when she's been having the infection. So you give this combination of drugs and IV zidovudin needs to be given here. This is also an important area where EMQs can be expected. like where do you want to give IV zidovudin, what is the dose and all, you can ask either SBA or EMQ, both of which can be expected. And suppose she is coming to you in preterm labor. So what you do is, apart from what we have just discussed, like nevirapine, zidovudin, lamivudin and everything, along with that, double up the dosage of tenofovir as well. That is known to reduce the, it is known to, it will reduce the load in infant. And especially whenever there is a baby which is born to a HIV positive mother, you put the baby on post-exposure prophylaxis, is it not? So if it's a preterm baby, then what happens? Probably taking oral PEP could be a little bit difficult in the baby. So that is the reason what we do is we give the drugs during the labor and before labor, so that, and you're adding this tenofovir in preterm labor, so that if you're adding one more drug, it is more effective. So it's going to preload the infant. So therefore, even if the baby is not being able to take the PEP, we can at least assure some kind of some kind of protection which is given through these drugs initially. So if she's presenting to you in labor, this drugs would be pretty much enough. But supposingly she's coming in preterm labor, do not forget to add double dosage of tenofovir, so that they will rapidly preload the infant. And this is very much important, because if the baby is not even able to take the post-exposure prophylaxis initially, at least little protection is assured. So now we'll discuss about the mode of delivery. As we have discussed the viral load, when do we check it up? Like in each trimester, then at 36 weeks, then at delivery. So again, at 36 weeks, whenever you take up the viral load, we take the decision for delivery. And always it's important that the delivery should be conducted in a setup where there is an attached pediatric care. So whenever the woman is on CART, and if the viral load is less than 50 copies, then the transmission rate is less than 0.5%. Another important point. Now she comes to you at 36 weeks. In order to decide the mode of delivery, now what you're doing is you're taking up a viral load test. At 36 weeks, if it is less than 50 copies, then there is no debate about it. You can directly go for a planned vaginal delivery, because if it is less than 50 copies, it means that the patient is very compliant and the viral load is pretty much under control. So the risk of transmission is less than 0.5%. So go for a vaginal delivery. And if it is more than or equivalent to 400, even if it is 400, you have to go for a pre-labor cesarean section. Even before she enters into the labor, go for a cesarean section. And if it is between 50 to 399, also we go for a pre-labor cesarean section. Only in less than 50, we go for a planned vaginal delivery. And we see conditions like VBAC, that is vaginal birth after cesarean, or even water birth, that can be offered if the woman is having a viral load of less than 50 copies. And supposingly, you do, so like you want to take up for a pre-labor cesarean section for some kind of obstetric indications. For example, if there is a cephalopelvic disproportion or anything like that, if you want to take up for obstetric indications, plan the cesarean at 39 weeks of gestation, because we see that the risk of having transient tachypnea of newborn at this age is 1 in 300 only. And if you try to perform it earlier, then the risk would be doubled up for every week. So therefore, there is nothing. Now the load is like, it is less than 50 copies per ml. That is well under control, HIV. But you're taking it the cesarean section only for obstetric indications. So there is no hurry. You can wait up to 39 weeks of gestation. Supposingly, you want to perform because of the viral load. In such cases, you perform it between 38 to 39 weeks of gestation. And whenever you're carrying it under 39 weeks, please make sure that you take up the antenatal corticosteroid. Maternal corticosteroid need to be given if you're performing it under 39 weeks. So let me again summarize. If you want to perform a cesarean only for obstetric indications, please do perform it after 39 weeks to reduce the risk of TTNB. And if you're performing it because of the viral load and you want to reduce the vertical transmission, you have to perform it between 38 to 39 weeks of gestation. And please make sure that you cover the steroid as well. Now, the woman is term and she's got a spontaneous rupture of membranes. Now, there is a membrane rupture. So there is a way for transmission of the HIV virus. So there is a possibility that there would be a cross infection, and there could be a transmission. There is an increased risk of transmission to the fetus. So what we do is, if the viral load is less than 50 copies per ml, you have to deliver within 24 hours. Whatever it is, you have to deliver the case within 24 hours. If a term case with HIV positive, she comes with a spontaneous rupture of membranes. So make sure that you have to deliver within 24 hours. And if it is less than 50 copies per ml, go for immediate induction or augmentation, and make sure that you deliver within 24 hours. Suppose it's more than 50 copies. If it's between 50 to 399, or even if it is like 400, do an immediate cesarean section so as to reduce the risk of the transmission. And suppose it's a preterm SROM. She comes in preterm and she's got a spontaneous rupture of membranes. What would you do? In such cases, if it is in 34 to 37 weeks, it is very, very similar to what you do for the term case only. That means if based on the viral load, you go for vaginal delivery or you do a cesarean section. But also make sure that the group B streptococcus prophylaxis, the GBS prophylaxis, needs to be covered here. That is one important point that you have to remember. And if it is less than 34 weeks, what do you want to do? You have to definitely cover the steroids. Plus, what you will do is you have to put up an MDT discussion. Sit along with a multidisciplinary team and decide whether you want to deliver, whether you do not want to deliver. If you want to deliver, what would be the mode of delivery? What if we can wait further? And all needs to be discussed, and the decision can be taken accordingly after you involve the consultant. So term and preterm SRO are very similar, that you only have to deliver. But if it is a preterm, make sure that you give the GBS prophylaxis. And if it is less than 34 weeks, make sure that you have to cover the steroids as well. And intrapartum zidovudin infusion. This is also an important slide where questions can be expected. So when do you want to go for an intrapartum zidovudin infusion? Like as we've just discussed, you give zidovudin like 2 mg per kg for initial 1 hour, followed by 1 mg. That is when the woman is not treated and if she's presenting to you directly in the labor. That is like one category. The other one is if she's presenting to you with a viral load of more than 1,000 copies, who's presenting to you in labor or with SROM, or who are admitted for pre-labor cesarean section. The load is high. And you wanted, now she's presenting to you in labor, or there is a membrane rupture. In such cases, you can go for a IV zidovudin infusion. And then whenever it can, you can consider it whenever the count is like less than 1,000 as well. You discuss with the MDT whether it is needed, not needed. Even when the load is less than 1,000, you can probably discuss. But the most important indication is in an untreated woman who's presenting to you in labor. You're not sure of what her count is, everything. You're not really sure. So start her on IV zidovudin infusion. And there is like one patient who you are already wanting to perform a cesarean section, but suddenly she comes to you in labor. Then what do? You have to go for an IV zidovudin infusion. So after the delivery, what you do is you have to make sure that you start the post-exposure prophylaxis within 4 hours of delivery, as early as possible, but within 4 hours. And they categorize them as very low, low, and high risk. When do you call the infant as very low risk is if the woman has been on CART for more than 10 weeks and there is a viral load of less than 50 copies which are taken 4 weeks apart, and the viral load is less than 50 copies per ml at or after 36 weeks. So when all the 3 criteria are fulfilled, which means that the mother is very compliant, the viral load is very low, such cases the risk of transmission to the child is almost negligible. So in such cases, just 2 weeks of zidovudin therapy needs to be given to the baby. The baby will now fall under very low risk. So 2 weeks of therapy would be sufficient. And if the criteria for the very low risk is not fulfilled, if any of the 3 is not fulfilled, the baby would come under low risk. And if the infant is born in less than 34 weeks, now there is it's a preterm baby. but the viral load is like good under control. Like if it is less than 50 copies, the child would come under low risk. So instead of 2 weeks, you have to go for 4 weeks of Zydovirin therapy. And what is the high risk? So for both very low risk and low risk, we give just Zydovirin monotherapy. That's it. But if there is a high risk, you have to go for a combination post-exposure prophylaxis. Like whenever you see that the viral load is more than 50 copies, any of the criteria which is not fitting into both low and very low would come under high. That is natural. So what do we do is, what is the regimen that you give is a total of 2 weeks of nevirapine and with 4 weeks of Zydovirin and Lamivudine. You need not know the doses and you need not know the combination. It's just that I'm just telling, but memorizing it is not required. But you need to know which comes under low risk and which comes under high risk and which would come under very low risk. When do you give 2 weeks therapy? When do you give 4 weeks? And when do you give combination therapy? This much you should be knowing. So when an infant has been started on combination PEP, because the maternal viral load was considered to be more than 50 copies, and subsequently, if it is shown less than 50 copies, then you can just switch to 4 weeks of Zydovirin monotherapy. Now, initially, you are thinking that probably you are not sure of the viral load, and when you are not sure, you will definitely put it under high risk. You're not going to take that risk of putting it under low risk, right? So you are assuming that the child could be under high risk, and you're starting on the post combination therapy. And then once the maternal viral load comes out to be less than 50 copies, it means that they will be fitting under the low risk. So you can switch to the 4 weeks of Zydovirin monotherapy. But we're not really sure whether they were compliant or not or whatever it is. But once you see that the load is less, you can switch back the baby from combination therapy to monotherapy. So for the child, is there any restrictions which are required? Absolutely not. The immunizations can be given as per the schedule, and cotrimoxazole should be prescribed from 4 weeks of age if the baby has been tested positive for HIV. And if there is a very low risk or a low risk, BCG can be given, and there is no need for any kind of delay. Rotavirus is not contraindicated unless the HIV diagnosis is confirmed and the baby is severely immunocompromised. But otherwise, we do not delay the vaccines for the baby. It can be given as per the schedule. So that was a crisp overview about HIV in pregnancy, an extremely important topic, which is you need to follow the BHIVA guideline, which has been updated in the year 2020. I hope this was useful to you. In case of any doubts, you could just let it know in the group, or you can just put it in the comments down below and we shall clarify. And do not forget to subscribe to the channel. I will see you all in another video. Bye.